Okay, part 2 of Chapter 10. We are now up to the part of Chapter 10, which basically finishing up the chapter is the discussion of shock. Shock is obviously a terrible concern when it comes to our patients, our critical patients that we deal with in EMS. Luckily, we don't see a lot of them in severe states of shock, because it is truly a very devastating condition for a person to be in. So this chart, and it's also found on 248 in your text, is really a very good representation of the whole shock pathogenesis, or the process of pathophysiology of shock. And it starts with inadequate tissue perfusion in the red box there. Now, for whatever reason that is, we'll discuss that in a little more depth in the upcoming slides. But when we have inadequate tissue perfusion, that means we're not getting good sugar and oxygen and potentially even water to the cells, which leads to an impaired glucose usage, which is going to do a couple of things. Number one, it's going to increase serum glucose levels, because it's going to the epi norepi dump, as well as the body saying, hey, I don't have enough sugar here, is going to cause the glucagon to be dispatched, and then that will start to free up some of the stored glycogen. It's going to also release the catecholamines, cortisol, and growth hormone. Catecholamines being mainly epinephrine and norepinephrine, as well as dopamine and a few small other ones. Cortisol is a stress hormone, and of course growth hormone has to do with growth. Those are going to lead to an increased lipid breakdown, or lipolysis, in order to try to get some sugar into the system. Increased glucose production, and we'll talk about that in a moment, and increased glycogen breakdown, which is going to decrease our energy reserves. The increased lipid breakdown increases the triglycerides and the fatty acids that are floating freely within the body. And then the increased glucose production comes from increases in breakdowns of proteins, which will increase the serum alanine, decrease the serum albumin, and increase the amino acids that are floating around in the body. This all increases pyruvic acid. And then the decreased colloid osmotic pressure means that the fluid is going to leak from the vessels, and it's going to worsen their hypotension. So while it's confusing, this helps give you a good idea that you see that a lot of it is based off of how well you can use your glucose. And when you're not using glucose efficiently and or not oxygenating well, then you have a lot of breakdown of various substances throughout the body, and an increase in certain other substances that are released into the body. And it's kind of a spiral that you go into, because you get that worsening hypotension, which leads to more inadequate tissue perfusion, which leads to impaired glucose usage, and on back to the line again. So all forms of shock share a final common pathway of inadequate cellular perfusion to meet the metabolic needs. It's just the pathway that they get there to that end result. So shock is the inadequate oxygen supply to meet the demand for oxygen at the cellular level. And with that comes sometimes decreases in fluid levels, decreases in sugar, but ultimately it's the oxygen is the one that's needed the quickest in order for the body to continue to function. So we talk about some common classifications of shock. And those four major classifications of shock are cardiogenic, hypovolemic, distributive, obstructive, and those generally get broken down into other basic causes, and we'll kind of talk about those as we get there. But all in all, they all end up being a decrease in end organ perfusion. So this one we're going to look at is hypovolemic shock. Now, this is probably the most commonly thought of type of shock that we deal with, and hypovolemic shock is a category that contains the most classic sense of shock, which is hemorrhagic shock. Hypovolemic itself means low fluid volume. So a low fluid volume, and in most cases when we say low fluid volume, we're actually talking about low blood volume. So this can be as a result of loss of blood volume. However, it can also be from things such as loss of water, from severe dehydration. So it's not only blood. So hypovolemic is low fluid volume, period. Hemorrhagic would be then loss of blood. So we have an insufficient blood volume within the vascular space, and then the tissues and the organs don't get adequately perfused. People generally do fairly well for a short period of time after losing some blood. They stick in compensated shock, and that's when the body is using its mechanisms to maintain. So let's go back and actually look at that last slide, which is the picture on page 1011 in your text. With that, we can see that decreased intravascular fluid volume, so there's less fluid in the vessels. It leads to a decrease in cardiac output. So the heart can't put out as much as it normally would. This causes several things to happen. Number one, it dispatches blood from the spleen. So the stored blood that's in the spleen is set free. It causes a discharge of antidiuretic hormone. A diuretic is a drug that causes you to lose excess water. So antidiuretic would be keep excess water. So it dispatches antidiuretic hormone. So it says keep all the water we can. It causes an interstitial fluid shift. So it pulls some of the water from in between the tissues and the cells, and it pulls it into the vascular space. It causes a release of aldosterone from the kidneys and the adrenal glands. The aldosterone works to maintain a salt balance. It retains salt. By retaining salt, it also retains water, and it causes a constriction of the peripheral vasculature. So, and it also causes an increase in catecholamine release. Catecholamines, again, being epinephrine and norepinephrine. Those catecholamines increase the heart rate. They increase the strength of contraction. They also cause some peripheral vasoconstriction and some central vasodilation. So it tries to keep the blood shunted to the core. A few of these things lead to increased intravascular volume, at least temporarily, as we shifted some fluids and we retained some fluids, and we released some from the spleen. In theory, this then increases our cardiac output because there's more fluid, plus there's more stimulation to beat harder, and the vessels are smaller. However, we're going to have continued fluid loss because if we increase the heart rate, we increase the blood pressure. If we don't plug the hole, we just continue to lose the fluid. This is then going to cause a decrease in cardiac output again. We're going to see a decreased systemic and pulmonary pressures because now we've cycled through this a couple of times now. There's just not nearly the reserves there that there was. And so pressures start to drop. This causes a decrease in tissue perfusion and finally impaired cellular metabolism. And I know these charts are kind of complex, but I think it does a good job of breaking down an even more complex concept. Okay. So if hypovolemic shock is not reversed before cell death and tissue damage occurs, the patient's going to enter an irreversible shock. And irreversible shock is just that. It is irreversible, and they die. from a failure of lungs, blood clotting disorders, multiple organs are failing, and it's just an ugly, ugly thing. Well, there's an ischemic phase to hypovolemic shock in which the precapillary and postcapillary sphincters close to shunt blood from the periphery to the vital organs. So that's where we start to get that pale look to us. Now, to demonstrate this, you can look on page 250 in your text. You can see that we have, obviously in blue, we have a venule, and the major one in red is an arterial, those being our major working blood vessels there, getting right down into that capillary network. Well, the capillaries all have these sphincters on them. Okay, sphincters, remember, are circular muscles. Probably our most commonly thought of sphincters are our mouth and our rectum, or anus actually. But those sphincters open and close to allow blood to be directed in certain areas. If all of our precapillary and postcapillary sphincters opened at one time, we would have so much open capillary space, we do not have enough blood in our body to fill it. So these are constantly in a state of some are open, some are closed, and they kind of are just always kind of open. You know, it's very random as opposed to who needs what at what time. So in the ischemic phase, the precapillary and postcapillary sphincters, so the sphincters on both sides are closed, not allowing blood to enter the capillary networks. So it keeps it in the bigger vessels, which in theory causes us to have more circulating blood volume. However, in reality, we lose the actual working part of the circulatory system, the part in which the cells get the stuff they need, and the stuff is taken away. So that's the ischemic phase. Then we get the stagnant phase. In the stagnant phase, then, the precapillary sphincter opens, and the blood enters the capillary bed. The postcapillary sphincter remains closed, and that blood stagnates. So over time, the body says, well, crap, I really got to get something to my cells. So let's open the precapillary sphincters. So blood then rushes into the capillary beds. However, the postcapillary sphincters, which actually drain the capillary bed, are still closed. So that blood rushes in there and it's stuck. Can't go anywhere. Can't be carried away. And then finally, we get a washout phase. In that washout phase, that postcapillary sphincter opens, that stagnated blood is washed out of the capillary bed. Well, by this time, they're probably getting to be so hypotensive and probably beginning to become unresponsive. If they're not completely unresponsive already, they are going to now be rushed with all kinds of waste product that have built up, and it now rushes back into the system, and it can be a fatal blow. So our signs and symptoms of hypovolemic shock are really those that are our classic shock presentation. So I think in most cases we can say a person that has tachycardia, tachypnea, hypotension, pale, cool, and clammy skin, slightly altered to completely altered mental status. That's kind of a classic look to shock. And so that's how most of our patients are going to present when we're talking about a hypovolemic shock patient. Now we're going to recap shock here in a couple of chapters down the line here, but this is kind of walking you through the pathophysiology of it. So hemorrhagic shock comes from various sources. Obviously blood loss. We may have not obvious blood loss. So when I talked in the first part of the chapter about the patient with the GI bleed that had the classic signs and symptoms of shock, that would be a non-obvious hemorrhagic shock. You can bleed easily a significant amount of blood inside your body and never have any outward signs. So we'll take, for example, if most people's lungs hold somewhere from 5 to 6 liters of air, if they could be fully inflated, your body holds somewhere from 5 to 6 liters of blood. So that in and of itself, you could bleed your entire blood volume out into your chest cavity. No problem. You can lose up to 2 liters per broken femur. You can lose another 2 liters for a broken pelvis. So that in and of itself is your entire blood volume again. So these things can be hidden. A decreased blood pressure is a very late sign of shock, meaning they've lost 25 to 35% of their blood volume. I think that is a paramount statement that you guys really need to keep in mind. That once we start to see a patient become hypotensive, they've lost a quarter to a third of their blood volume. Quarter to a third of their blood volume. They don't even start to show low blood pressures until they're halfway, a quarter to a third of the way, done. Now the stages of hemorrhagic shock, this is really not something that I'm probably going to test you much on, but it is something I think it's good to keep in mind. We have basically 4 classes of hemorrhage, and the classification of their hemorrhage is based off of the percent of blood volume lost. And the example they give in the chart here is with a 70 kilogram adult and the approximate amount of blood they would have had to have lost. So up to 15%, this is usually well tolerated. They can usually have a little bit of mild tachycardia. They may not even realize that there's something terribly wrong. They may just feel a little not well, not themselves. A class 2 hemorrhage is 15 to 30%, and so that would be 750 to 1500 mLs. They're probably going to have moderate tachycardia, so into the 120s, 130s. Pale skin, delayed capillary refill. So now we're starting to be able to actually even pinpoint this off of just a basic quick primary survey of this patient. Class 3 hemorrhage, roughly 30 to 40% of their blood volume is lost. They now have significant tachycardia, 130 plus probably. It may not be quite as high. There's some other cases in which we need to talk about, but failure to compensate, so now they're now becoming hypotensive, like we said on the previous slide there. And then there's a class 4 hemorrhage. They've lost 40 to 50% of their blood volume. They have profound hypotension. They have end organ failure. Probably have gone now into bradycardia. They probably have bradypnea. Anuria that they list there, they're not producing urine. Not something we're going to probably know in the field, but we'll definitely know bradycardia and bradypnea, and it's most likely going to lead to death. All right, to move on to the next type of shock, cardiogenic shock. So we talked about hypovolemic shock, where the blood was the problem, or the fluid actually was the problem, because it can be, remember, from things such as severe dehydration. So cardiogenic shock, this is a pump problem. So the heart has begun to fail. So let's look at this diagram. So we have a myocardial dysfunction. So the heart is not pumping efficiently. For those of you guys who maybe need to think about this in a little different manner, think about if you have an 8-cylinder engine, you have a V8 in your vehicle, and you're only able to pump 7 of those cylinders. One of them has gone bad. How well is the car going to run? Might it run? It might. But will it run efficiently and well and smooth? No. So this is the same sort of thing. So number one, when we get this myocardial dysfunction, so we'll say we've had a heart attack, part of our heart muscle died. We can have systolic dysfunction, which is a decrease in cardiac output. And that decrease in cardiac output also is a decrease in stroke volume. Those two things come from the systolic side of things, or the heart at work. We've also got the diastolic side of things, which is the heart at rest. So we're going to have an increased left ventricular end diastolic pressure, which leads to pulmonary congestion. So basically what this is saying is when the left ventricle has too much pressure, the blood can't easily fill it, it backs up. So it's backing up. Where does the left side of the heart get its blood from? It gets it from the lungs. So therefore the blood backs up into the lungs, and the lungs start to get a little leaky, and you get pulmonary So back to the systolic side of things. When we have this decreased cardiac output and this decreased stroke volume. So cardiac output is the amount of blood we pump through the system really in a minute's time. And the decreased stroke volume, that is the part of that decreased cardiac output. It's with each pump of the heart, how much blood is ejected. So a couple things happen here. We don't have the good cardiac output. We get an activation of the renin-angiotensin system, which we talked about that before, saying that leads to some vasoconstriction, some retaining of salts and waters. We again will dispatch some more antidiuretic hormone, which keeps more blood or keeps more urine, keeps more water in the body by decreasing the amount of urine. We have increased aldosterone, which is also responsible for some salts and water retention. The catecholamines again released, so the epi and the norepi, as well as dopamine, are going to be released, and this is going to help increase the systemic vascular resistance. So the catecholamines help constrict the periphery, and they may dilate a little bit around the heart and potentially the lungs. Those first three there help increase the blood volume by either retaining, constricting, or producing. So then we have an increased blood volume, which is going to increase the preload to the heart, which is generally a good thing. It'll increase the heart rate because that's what the catecholamines do, and it will increase the stroke volume. So in theory, it makes things better. However, this also increases the cardiac workload. We already have a weak heart that isn't functioning at capacity, so then it starts to gobble up more oxygen. And as it gobbles up more oxygen, it wears out. Turns out that it starts to decrease the cardiac output. It decreases the ejection fraction, which is the amount of blood that's pumped out. And you see a fall in the blood pressure. You also see this decrease in tissue perfusion, which leads then to the impaired cellular metabolism. So this is kind of the whole chain of events that happens with the cardiogenic shock. It's a pretty bad deal. Cardiogenic shock is not something that people do well with. So the heart cannot pump sufficient amounts of blood to maintain an effective cardiac output. And the most common cause of this is myocardial infarction. This may be a myocardial infarction that happened 2 or 3 days ago. It may have happened 2 or 3 months ago. It all kind of depends on when it comes on. If you have the person who you go to pick up, they're feeling short of breath, and weak, and tired, and you start talking to them a little bit. How have you been feeling lately? Well, I had a little chest pain a couple of days ago, and I didn't think much of it. I've had it before. Didn't go in to see the doctor. Well, wonder if it could have been an MI, and now this person could be in cardiogenic shock. So, does not pump sufficient blood to maintain what the body needs. Occasionally there are other things that cause it, such as a cardiac dysrhythmia. Dysrhythmia means that it's a bad rhythm. So if we want to go back and talk our street language, when you be dissing somebody, you be talking bad about them. Okay, so bad rhythm. When they have a bad rhythm, they can be going too fast, they can be going too slow, or it can be very irregular, and the heart is not able to efficiently pump the blood that's needed. It can be caused by cardiomyopathy. Cardiomyopathy is a disease of the heart muscle itself. Usually it leads to very enlarged hearts. Could be an infection of the heart muscle itself. Could be a cardiac valve malfunctions. They may have a mitral valve that is not working efficiently, or more likely, it's probably that they have a mitral valve or a pulmonic valve that is, take that back, mitral valve or an aortic valve that is not functioning appropriately. It causes some blood to be retained in that left side and therefore not ejected correctly. So patients present with chest pain and may have pulmonary edema. They may have chest pain. They say it in here like it's always. It's not always. chest pain in these cases is very much like many of our other chest pain patients, is they don't read the book, they don't know they're supposed to have chest pain. So, and the pulmonary edema, early in the process, they're probably not going to have pulmonary edema. Shortly down the road, you usually will see that then come on. So our pre-hospital treatment is supporting the ABCs. So there's various medications and electrical therapies that the paramedics can perform to help correct the underlying cause. The mortality rate very high. So a lot of people die from cardiogenic shock. They just don't have the heart. All right, now we move on to neurogenic shock, which when we were talking about shock before, we were like, we didn't talk about neurogenic. But if you look up at the top of the page 253, we're actually talking about a distributive shock. So this is a form of distributive shock, probably the more common of the distributive shocks that we will commonly discuss. So, well, one of the more common. So what we have in a neurogenic shock, that picture is on 253 in your text. We have a spinal cord injury, which leads to the autonomic nervous system imbalance. Okay, crap. Now we got to go back and think about nervous system again. The nervous system has, central and peripheral. The peripheral has autonomic and voluntary. And then the autonomic system breaks down into the sympathetic and the parasympathetic nervous system. Sympathetic is the fight or flight, parasympathetic is rest and digest. So with the autonomic or the automatic nervous system, things just kind of change on their own. We're not thinking about it. So with that, we lose the autonomic nervous system. So the tone is not there. The constant reminder for the vessels to remain hunkered down is gone. So the boss is gone. What happens, when the cat's away, the mice will play, right? Well, if the nervous system isn't telling the blood vessels constrict and be this size in order to make sure the blood flow, the vessels are going to say, like, yeah, what the heck, let's take it easy, let's just relax. And so everybody relaxes, they all vasodilate. And what happens then is there's now vessels that are way too big to contain the amount of blood that we actually have. So with that massive vasodilation, the peripheral vascular resistance, or systemic vascular resistance, either one, is reduced. There's just not that resistance there. You get a massive vasodilation again, which like how they put that in there twice, leads to an inadequate cardiac output, and that inadequate cardiac output leads to a decreased tissue perfusion and an impaired cellular metabolism. Now, in addition to neurogenic shock, we may have one of the other types of shock, distributive shock. So like I said, uncontrolled vasodilation, creating a container too large. So this is a pipe problem. We have neurogenic, that's the loss of the sympathetic tone results in uncontrolled vasodilation below the injury site. Sometimes these people, you look at them, they have a line of demarcation where basically you can almost, if you remember when we looked at the dermatome map, you can almost trace the dermatome map right across their body where it's pink, warm, and dry in one spot, and it's pale, cool, and clammy in the other. Distributive shock also has a number of pre-hospital treatments. Immobilization of the spine in the case of a spinal injury, or in the case of a patient who has suspected spinal trauma. Airway management, support ventilation, because if they've damaged the spinal cord, chances are good they've damaged some spinal nerves. Supplemental O2, keep them warm, and we can give them some IV fluids to help try to fill up some of that container. We also have anaphylactic shock. And anaphylactic shock is another form of distributive. So as we look at this one on page 254 in your text, you'll see that there was an exposure to an antigen at some point in their life, and nothing really actually happened, and other than the body started to build up antibodies to that antigen. At some point down the road, the person was exposed to it again. You're never allergic to anything the first time you come into contact with it. It's second or subsequent times. It doesn't have to be the second. It can be the 402nd. But you have this repeat exposure to the same antigen. It causes a large release of an antibody called IgE. We'll come back to that when we get to that chapter, but which releases a massive amount of histamines, prostaglandins, and kinins. All of these are various mediators and various substances that are intended to go destroy invaders. So heparin can also be thrown in there. So if you know what heparin does, heparin dissolves things, dissolves blood clots. So when we have this massive histamine, prostaglandin, kinin release, we see bronchoconstriction because the body's like, I don't want any more of it in here, keep it out. Laryngeal spasm, same sort of thing. And we also have gastrointestinal cramps, vomiting, and diarrhea, which the body's now saying, get anything that's still in here out. So something's in here, we don't want more in, and let's get out whatever we have. It also causes an increase in capillary permeability. So the walls of the capillaries, which are dilated, now are starting to leak, which causes edema. We also get peripheral vasodilation. We get systemic vascular resistance drops. We get a relative hypovolemia, basically saying we don't have enough blood volume to fill the big pipes we have. Causes a decrease in cardiac output, a decrease in tissue perfusion, and then finally impaired cellular metabolism. Well, we kind of have that same thing constantly going there. Impaired cellular metabolism. So, anaphylactic shock is a result of a very severe system-wide allergic reaction. Very common causes are medications, insects and wildlife, animal bites and stings, and peanuts. So when they say antibiotics on the slide, antibiotics are fairly common, particularly the penicillins and the sulfas, but we also see this with aspirin and various other medications. Oddly enough, we hear about people who will tell us that they're allergic to Benadryl, which in reality they're probably not allergic to the diphenhydramine, but Benadryl is almost always pink in color, and they're more commonly allergic to the red dye. So if you go looking around at some of your over-the-counter medications anymore, you'll see a lot of them have become clear, or the coloring, they'll offer it minus the coloring. So hymenoptera, that's the flying stinging insects like bees and wasps, but you can also have others like some people will have very bad reactions to certain sea life, whether they eat it or they're stung by it. All right, an anaphylactic shock, a distributive shock, very quickly can lead to death. This really goes fast when you see this. The signs or symptoms that you would commonly see: hives, itching in the throat, stridor, wheezing, abdominal cramping, and airway swelling. So none of that should be new. Should be kind of a review from what you know from EMT. And then the final major form of distributive shock we talk about is septic shock. And septic shock is big, it's bad, it's ugly, and people die from it. I mean, any type of shock people can die from, but it's not, once you get into septic shock, it's usually not a good thing. So to review this is a little bit more ugly on 255 in your text. You have this systemic inflammatory response syndrome, or SIRS, what they refer to it. You're having a fairly significant infection within your body. The body basically is overloaded, overstimulated, and says, whoa, I got to do something. I'm just filled with crap. I got to get all this infectious crap out of me. So it activates a number of cells, the white blood cells, the platelets, and the other immune responses, which in turn are going to release a lot of chemical mediators of inflammation, because inflammation has some standard signs, some standard reactions, things like we get a fever to try to burn off that infection. We get redness because there's an increase in blood flow to an area. We get swelling because of the increase of blood flow and in turn some leaky capillaries and edema in the area. We get tenderness mainly from all the extra swelling there. So all of those things kind of come along as the standard septic shock or standard inflammatory response. With the release of these multiple chemical mediators of inflammation, and a lot of those are very similar to what we saw in anaphylactic shock. We see some histamines and some kinins being dispatched as well. We get some endothelial damage, which means linings are damaged. And it can lead to hypotension as the fluids are leaking easier, tissue necrosis because that endothelial, which is a lining or a coating, is not there to be protective. We see lactic acidosis because there's so much death and byproduct. Cardiac depression because the heart is being under fire too. The heart has linings. We have decreases in platelets. We have vascular leakage, which can lead also to pulmonary congestion. We have decreased systemic vascular resistance as fluids are starting to shift and vessels are starting to dilate, and we have decreases in white blood cells. So it is a massive, massive assault on the body. It can present very dramatically with high fevers, although they don't always have a fever at all. Tachycardia, respiratory distress, decreased mental status, and hypotension. Our pre-hospital treatment include basic ABCs and trying to help control body temperature. There's not a lot we can do in the field other than basic supportive measures. We don't have super mega antibiotics, and even the antibiotics don't always work when they're in the hospital for weeks and months on end. The final form of shock is obstructive. And obstructive shock is a physical obstruction, blocking the forward flow of blood through the circulatory system. The most common causes that we see: pulmonary embolism, tension pneumothorax, and pericardial tamponade. So, define each of those. Pulmonary embolism. I talked about that earlier in the chapter, where a pulmonary embolus is a blood clot in a portion of the circulation that feeds to and from the lungs. So it's not actually a lung issue. The air moves in and out, the alveoli work fine. The problem is the blood that is going around the alveoli is blocked. Eventually it will lead to problems with the lung and the alveoli. But tension pneumothorax. Pneumothorax is a collapsed lung. It becomes a tension pneumothorax when that lung has leaked so much air into the pleural space that it is now compressing that the injured lung, the heart, and the unaffected lung. So there's air trapped in between the pleura, or the pleural linings, and it is pushing on everything. And pericardial tamponade. We have the pericardial sac, which the heart sits in. It's a nice, tough, protective layer that protects the actual muscle part of the heart. There is space between the pericardium and the heart itself. That space usually has a very small amount of fluid in there that's kind of designed to be a lubricant. Occasionally there's an infection or a trauma that actually causes there to be an excessive amount of fluid, whether that's blood or an infectious fluid, pus, that fills that. That pericardial sac does not stretch well. It's intended to allow the heart to beat, but it does not allow the heart to stretch beyond a certain point. And so when that pericardium is maxed out, the pressure, the blood or the fluid that continues to flow into it is still flowing, and it puts pressure inward on the heart itself. So it actually is suffocating the heart. So the pathophysiology of shock really says, regardless of the underlying cause, the initial signs and symptoms of shock are external manifestations of the body's compensatory reactions to hypoperfusion. And as shock progresses, signs and symptoms reflect the failure of the compensatory mechanisms. Now note that we didn't have a nice chart on our obstructive shocks. You can see good representation pictures of what those actually have, what the problem actually is on 256. But in reality, if we just think for a moment, a pulmonary embolism, we're not oxygenating well, not to mention some of the blood is blocked. A tension pneumothorax puts pressure on the heart. Pericardial tamponade also puts pressure on the heart, so therefore it doesn't effectively allow the heart to pump at its best. So any of those things are going to alter the output that comes from the heart. So our pathophysiology, many of those signs and symptoms are due to the epi and norepi or the catecholamine release. So the anxiety, the pale, cool, sweaty skin, tachycardia, nausea, vomiting, those all come from that dump, as well as we may start to see some things such as thirst, decreased urinary output, and increased respiratory rate that comes from the either the signs or symptoms of epi-norepi release and or some of the other hormones, such as the renin, angiotensin, and aldosterone. As an AEMT, your role is to anticipate and recognize shock quickly, provide appropriate field interventions, and transport to the closest facility capable of providing care that the patient needs. If we're able to start to pinpoint some of the issues here, we may want to make some decisions to transport to a different facility based off of what we find, say a trauma center. All right, so children and geriatric patients do not exhibit the same signs and symptoms as an adult. How might these signs or symptoms differ? Well, children and geriatrics, as we learned in the lifespan development chapters, they don't always have the same compensatory mechanisms. Children haven't built them yet. The geriatric patients have worn them out. So geriatric patients may always be a little tachycardic, and it'd be harder to determine that they're tachycardic. Pediatric patients are always tachycardic until they get older. Geriatric patients often have a lot of medical problems that compound this, so they may be taking some medications that help reduce their heart rate or reduce their blood pressure. So that's going to alter the way that they appear. Kids do a very good job of compensating to a point, and once they're done compensating, they're done. So kids have strong hearts almost always, except in case of weird congenital things. The heart is good, and it's actually not a weak heart unless it was something congenital. In heat and cold emergencies, the body is constantly adjusting to the changes in the internal and external environment. We have a normal core temp of either 98.6 or 37 degrees Celsius and 86 Fahrenheit. Increased physiologic activity generates heat. So if we're working out, we generate heat. If the body's working harder to kill off an infection, it generates heat. If the body is burning lots of sugar, generating heat. So when the core temperature drops, the body adjusts to increase that heat production and decrease heat loss. So it's going to shunt blood to the core. It's going to constrict those peripheral vessels to help keep the heat in, trying to basically stay away from that cold, drafty window that is your skin and towards the middle of the room or the middle of the house where it's a little warmer. It's moving that blood that way. The body starts to shiver. The shivering is that involuntary muscle use and contraction, which increases the amount of heat that the body produces. When then the body can no longer compensate for that environmental extreme or temperature regulation mechanisms are impaired, death can occur. There are certain people, particularly more often the elderly, that their thermoregulating systems are shot. Hence the reason why if you ever go into a nursing home, it's about 400 degrees in there, and people are still sitting around wearing sweaters. They've lost their ability to thermoregulate. It doesn't function nearly as well. so they keep it warmer typically. All right, so in summary, diseases and injuries often present as emergencies when pathophysiology results in inadequate cellular energy production to maintain cellular function. Our pre-hospital treatment is all based off of maintaining ABCs and the basic building blocks of life. So we make sure that the body's got oxygen, it's got water, it's got glucose, and we keep them warm. So we provide those general supportive treatments, and so having this basic understanding of pathophys can help us get a better picture of what the patient's problem is. Now, we are by no means done with pathophysiology. We're going to continue to see pathophysiology throughout all the different emergencies that we talk about in the text, but this gives us the broader perspective on it. As we get to the individual emergencies, we'll talk a little bit more about how the pathophysiology affects them.